Hello, my name is Michael Krease. I finished my internal medicine residency at OSU in 2016, 4 years ago now, which I can't believe it's been that long. Then I did my gastroenterology fellowship at the University of Louisville here in Kentucky, and I stayed in Louisville after my fellowship, which is where I now work. And I recently gave this talk at the STAB Symposium, and I'm happy to be able to give it here for the residents on Zoom. So I'm going to talk about GERD, which some of you may be able to figure out what I'm referring to when I say the other silent killer, but that's, of course, Barrett's esophagus. This is a picture of Norman Barrett, who is actually an Australian surgeon. And as much as I don't like to give credit to any surgeons, was pretty important in the field of Barrett's esophagus, which we now know quite a bit about. So GERD's very common. No matter what you do, whether it's be a hospitalist or stay in outpatient primary care, subspecialized, you're going to be dealing with GERD. Up to 20% of Americans, this is data from 2017, on a survey study, admitted to having any type of GERD, and it may be more common from stuff I've read more recently. This is from 1997. This is from Olmsted County up in Minnesota. It was just another survey study. They asked people if they had heartburn or acid regurgitation. They defined heartburn as a burning pain behind your breastbone, or acid regurgitation as a sour taste or a bitter taste coming up from your stomach kind of up into your mouth. And I want to direct your eyes over here to the subtotal of all men. 42.9%, 43% reported that they had any heartburn at all. Pretty high number. If they were asked, do you have acid regurgitation, 45% admitted they had any acid regurgitation at all. If you go down to women, pretty similar numbers. 41, almost 42% of all women reported they had any heartburn. So you can see it's incredibly common. This is the same study, same data, just basically in a different form. Men on top, women on the bottom. And you can see that basically, whether you were young or old, your prevalence of heartburn as a man or a woman stayed the same. So this is something that can affect young people, and it continues to affect you as you age. So what is it? Well, it's basically what we just described. It's the classic symptoms are either having a sensation of heartburn, that burning sensation right behind your breastbone, or regurgitation, the perception that things are moving backwards from your stomach into your esophagus and occasionally up into your mouth. There are some atypical symptoms I want to touch on briefly. This is a recent practice update that the AGA put out a couple years ago, and it goes over some quote-unquote extra esophageal manifestations. There's three main ones that I want to talk about, or at least mention: hoarseness, cough, and asthma. A lot of these have very loose associations and not much data behind them, but just be aware that these three, hoarseness, cough, and asthma, can potentially be attributed to gastroesophageal reflux. So what are some risk factors for GERD? There's quite a few. Obesity is incredibly common, one of the most common risk factors for GERD. And putting this together, I was reading a lot of epidemiology data, and as the rate of obesity in the United States has gone up, the rate of GERD is exactly mirrored and paralleled that. Pregnancy, both of these have to do with increased intra-abdominal pressure that I'll show you here in a minute. Scleroderma, that can affect the whole body, but specifically how it affects the esophagus is it creates a motility issue, so you're unable to clear acid that does reflux upward, similar to achalasia in that regard, although those two are different. Down in the bottom left there is a hiatal hernia. This is a big one because normally your lower esophageal sphincter and your diaphragmatic crura perfectly align, creating a natural anatomic barrier to acid refluxing upward. When you displace part of that stomach upward, your lower esophageal sphincter is now above your diaphragmatic hernia, and you lose that natural anatomic barrier. So when someone says they have a hiatal hernia that causes them problems, really the only problems that hiatal hernias in general cause are they make your acid reflux worse. And then lastly, gastroparesis makes sense. If you're not clearing things forward, acid builds up and has a higher chance of refluxing backwards. So this was a study that came out in Annals of Internal Medicine back, 15 years ago now. And really what this is showing, it's looking at obesity and its association, your BMI and its association with GERD. And what it showed very clearly is that as your BMI went up, your incidence of GERD or risk of GERD also went up. And this is why. This is also why pregnancy can give you GERD. It's because you have an elevated intragastric, intra-abdominal pressure. You can see here, the white bars are normal BMI, and it goes up until obese, which is the dark bars. And whether you're expiring or inspiring, the pressure in your stomach is higher, which creates a driving force for acid to reflux backwards. But not everybody who's obese, or not everybody with, that gets pregnant has reflux. And this is why we have a lot of protective mechanisms. Saliva is probably one of the most important ones. It's a natural buffer, acid buffer. I mentioned esophageal motility. The esophagus is not just a tube. When you swallow food, it doesn't go to your stomach just by gravity alone. It's a muscle. And even when you're not eating, it's constantly propelling things down, so that if acid does reflux up, it's naturally trying to clear it back down into the stomach. I mentioned the GE junction and having the sort of natural anatomic barrier between your LES and your diaphragmatic crura. And then fundic relaxation. What's that? Well, this is the fundus of your stomach here, kind of the top portion right there that I'm circling with the mouse. When you eat a meal, your fundus relaxes, lowering your intragastric pressure, trying to prevent anything from refluxing upward. And then again, gastric emptying makes sense, that if your stomach, you have the migrating motor complex, even in between meals, it's constantly moving things through your stomach into your small bowel, again, not letting acid build up so that it can't reflux upward. This is similar thing, just kind of with pictures here. Again, we talked about esophageal dysmotility. We talked about the hiatal hernia. I really want to bring up the TLESR. That's a transient lower esophageal sphincter relaxation. And this is probably the largest driving force for why reflux is so common in the United States. The TLESR is a natural relaxation of your lower esophageal sphincter. And the caveat to that is that it's not associated with some of the other natural protective mechanisms. Your esophageal sphincter relaxes when you eat a meal, but you're also increasing your saliva production. You're increasing your esophageal motility. A TLESR occurs, you don't have those natural protective mechanisms helping, and by definition, they last for more than 10 seconds. And that's one of the biggest reasons why people have reflux, is they have a lot of TLESRs. Again, obesity and gastroparesis we mentioned. So how do you diagnose GERD? Simply by talking to patients. Do you have the typical symptoms that we mentioned of heartburn, that burning sensation, regurgitation, feeling sourness or bitterness going all the way up into your mouth? If they say yes to those, then they have heartburn. A lot of times you have to break it down into those: heartburn, regurgitation, or even acid reflux. If you ask someone, do you have GERD? I can't tell you how many times I've said, no, I don't have GERD. You ask them, no, do you have acid reflux or heartburn? And they say, yes, of course I do. Do you need to scope them? As much as I wish I could say yes here, you do not always need to scope them. There's really, you only need to scope them, and of course I'm referring to an EGD, if they have alarm symptoms. There are some caveats to that when we talk about Barrett's esophagus that I'll mention later, but in general, just remember, if you diagnose someone with GERD, they do not need an EGD unless there are alarm symptoms: difficulty swallowing, dysphagia, weight loss, any blood in your stool or iron deficiency, odynophagia or pain, chest pain. Those would be reasons why somebody with GERD would need to be scoped. And there's a whole bunch of tests that you can do, but you don't need to do most of them. First step after you diagnose someone with GERD is to put them on a PPI trial. What's that? 8 weeks of a PPI. So if you diagnose someone with GERD, put them on a proton pump inhibitor for 8 weeks. If it goes away, obviously you've clinched your diagnosis. You did before you put them on a PPI, to be honest. But if it doesn't help, that does not rule out that they're having acid reflux. Barium swallow, no role for it. You don't need to do it. Endoscopy, we mentioned, only if there's the presence of alarm symptoms. Esophageal biopsy has no role in the diagnosis of GERD. Esophageal manometry and reflux monitoring are interesting. Both are used primarily in the preoperative evaluation for someone that's going to get anti-reflux surgery. Esophageal manometry you wouldn't want to do, say, Nissen fundoplication in someone that ended up having scleroderma, which is how you diagnose, scleroderma esophagus or achalasia. It's with manometry. But if you did surgery for someone's reflux and they ended up having achalasia or scleroderma, they're probably not going to get much benefit because their esophagus really is not working. And so that is where We use esophageal manometry. Same thing for reflux monitoring. I'll talk about in a little more detail. It's used primarily preoperatively, but it is occasionally used when the GERD is completely refractory to everything, or if for some reason your diagnosis is questionable. But this is one of two systems. This is the Bravo pH system. This is wireless. You place it with the scope. You clip it proximal to the GE junction, about 5 centimeters, and it stays on for anywhere from 2 to 4 days. The patient wears a receiver that you can see there, and they can click the receiver when they're having symptoms, and it can correlate to what their acid pH is. And after about 5 days, this little receiver here falls off. And again, primarily this is only used in the preoperative evaluation for patients that are considering anti-reflux surgery. So why do we care? Well, there's a lot of reasons why we care. This is the middle picture here is normal. You have the normal esophageal squamous epithelium coming down. You see the ring there, and then your gastric columnar epithelium starts. So that's normal. Well, what happens when you have acid refluxing? I direct your eyes to the bottom right there. That's erosive esophagitis. Number one, it looks painful. And number two, as that heals, it can lead to stricturing, which you see there on the bottom left. Cause food to get stuck. That you can lose weight if it's bad enough, not able to eat. And so this is what we're trying to prevent when we diagnose and then treat GERD. It can also, all that erosive esophagitis and acid refluxing over time can lead to Barrett's esophagus, which is squamous to columnar metaplasia in your esophagus. So you basically get upward displacement of your normal esophageal squamous epithelium, which you can see there in the middle. So that circle is the top of your gastric folds, and you can see the Z-line is much higher, whereas on the left, the top of the gastric folds is right where your Z-line is. Over on the right, you can see probably about 5 to 7 centimeters of upward displacement of that normal esophageal squamous mucosa, which is the light colored mucosa there, and then that salmon colored mucosa below it. That's the gastric columnar epithelium that's come up. And this is important, obviously, because it is a stepwise progression that ultimately can end in esophageal adenocarcinoma. So how do we manage it? How do we treat it? Well, much like everything, whether it's high blood pressure, cholesterol issues, really you should always recommend lifestyle modifications to patients. Number one being weight loss, and it doesn't take much. 5 pounds of weight loss, patients will notice a big improvement in symptoms. And of course, this is only for patients that are already obese, have BMI over 25. Elevation of the head of the bed, there's a bunch of ways to do it. This is a pillow that's sort of triangulated to keep you a little bit upright. There's pillows you can see here that you would think are maybe uncomfortable. These people clearly look fairly comfortable here. You can get a bed frame that elevates you. You can get these bed risers, and these are literally marketed as GERD acid reflux bed risers. You type in GERD pillow on Amazon and you get 424 results. Avoiding late night meals, particularly high fat meals within 2 to 3 hours of eating. What about tobacco and alcohol? It's actually not recommended that you recommend to all patients to avoid tobacco and alcohol simply for GERD management. Now, obviously, you would want to recommend tobacco cessation to everybody, but in terms of specifically to help your GERD symptoms, unless they tell you it specifically makes it worse, you do not need to pigeonhole everybody into this bucket of no smoking. Same thing goes for certain foods. The typical foods that we always think of, chocolate, caffeine, spicy foods, carbonation, those things that we normally think make heartburn worse. The ACG, which is where these recommendations come from, these guidelines come from, do not recommend that you should recommend everybody with GERD avoids those things. But they tell you they have a specific trigger, coffee, pop, well, then obviously you would recommend they avoid those. But don't tell everybody to avoid all these things just for their management of GERD. We do have a lot of medicines. 3 main classes, the antacids, the H2 blockers, and the PPIs. These are the antacids here, Tums, Rolaids, Pepto. They're just like your saliva. They're buffers. They buffer acid that's already there. Then we have the H2 blockers. Zantac, it's been recalled twice, so really we don't use that much anymore, to be honest. Pepsid, which is famotidine, it has been out for a long time, and Tagamet. And lastly, we have the PPIs, the proton pump inhibitors. There's 7 of them. Most of them, a couple of them are over the counter. They all work identically. You can think of them really in that way, that they're all the same, except for Zegrid, which really isn't that commonly used anymore, to be honest. It is one of the ones that's over the counter. It's omeprazole plus bicarbonate. So how do we treat GERD? Why do we use PPIs over H2 blockers? This is why. This is the article that came out in 1997 in Gastroenterology that in every ACG guideline update is cited as the reason why we manage GERD the way we do. So let's start by looking at the left here. So this is meta-analysis, by the way. So this is H2 blockers on the left, and this is the percentage of patients that are symptomatic. And look at baseline. Let's just look at the middle two bars there. 74.2% of patients at baseline in this study that were going to be put on an H2 blocker reported mild to moderate heartburn symptoms. They were all put on H2 blockers, and the percentage of them that were symptomatic are reported here at 2, 4, 6, and 8 weeks. You can see at 6 weeks, there was some improvement, 24.2%, but still 50% of patients reported mild to moderate symptoms. Compare that to the right here. This is with PPIs. Omeprazole was the PPI of choice for this study. Baseline, 64.3% of patients reported mild to moderate symptoms. They were put on omeprazole 40 milligrams daily. And again, the percentage of symptomatic patients was documented at 2, 4, 6, and 8 weeks. And you can see that 6 weeks, only 4% of patients were still reporting symptoms. And this was carried out over time. Patients on PPIs continued to show not only improvement in symptoms, but this also showed improvement in the healing of erosive esophagitis compared to H2 blockers. They healed faster, got symptom-free faster, and maintained those improvements over time longer than with H2 blockers because of tachyphylaxis, really, that you get with H2 blockers. So these are some bullet points pulled directly from the ACG guidelines. First step after lifestyle modifications is an 8-week course of your proton pump inhibitor of choice that's usually dictated by insurance. That's for symptom control and to heal erosive esophagitis. Always start at once daily dosing and tailor that based on the response. Give it at least a couple weeks before you change though. And remember, these need to be taken prior to meals. There are some caveats to that we'll touch on the next slide. Maintenance PPI should be used for those that have recurrent symptoms after discontinuation of their proton pump inhibitor. Again, always at the lowest effective dose. You can use an H2 blocker at bedtime. That's really sort of the lane for H2 blockers right now, honestly, is someone that's on a PPI and still maybe get symptoms at nighttime. You can put them on an H2 blocker at bedtime. Helps a lot. But again, remember about tachyphylaxis. And I do want to mention Carafate, Sucralfate here briefly. That's the ACG guidelines specifically say that there is no role for Sucralfate in the non-pregnant GERD patient. And what Carafate does is in an acid environment, it coats the stomach, coats ulcers. When you take it with a proton pump inhibitor, your pH, the pH in your stomach goes way up when you take, say omeprazole. So really Sucralfate doesn't work anyway in that environment. Now, I will tell you, if you put someone on PPI and they say it doesn't help, you add an H2 blocker, they say it doesn't help, they're miserable, you scope them, it's normal. You can try Carafate, it won't hurt. And sometimes they say it helps, well, keep them on it. Just remember, you can't take it around other medicines, particularly blood thinners or immunosuppressive agents for, whatever, for organ transplant. So, because it can affect the absorption. But in general, remember, really, there's no role for Sucralfate in the non-pregnant GERD patient. So these are the 7 PPIs over here on the left. Again, Zegrid was that omeprazole bicarbonate. There's no convincing data that any one of these is superior to another. And that's why you should think of all of them as the same. Now, I'll tell you that dexlansoprazole, which at the bottom there, is the most expensive, hardest to get approved, but for whatever reason, people seem to say it works better than others. But in general, there's no data that any one's better than the other. All of them should be dosed 30 to 60 minutes prior to a meal. There's 2 exceptions to that. One is the omeprazole bicarbonate. And the role for this really is taking it at bedtime if you're going to have someone on it. And then dexlansoprazole. Dexlansoprazole is a little bit different in how it works than the others. It's a dual delayed release PPI, meaning some of it is absorbed or released at a low pH in your small bowel, and then later on the rest of it's released at a higher pH as it traverses through your small bowel. And that one does not need to be taken in relationship to a meal. But it's very common if someone comes in that you put on omeprazole 40 milligrams daily, which, by the way, omeprazole is by far the most common of all these. 75 billion prescriptions were filled for it last year. Pantoprazole is number 2, 25 million. or 25 billion prescriptions were filled for it. But if you put them on it, they come back and say, I'm no better. Ask them when you take it. I bet you most of them will tell you they take it at bedtime. So always, always, always remember to tell them to take it prior to a meal. Talking about safety, in general, they're very safe, even though the news might have you think otherwise. In 2016, that's when all these screenshots were from. The news, particularly NBC, took this study that came out from Germany that was published in the New England Journal, actually, and they took it and ran with it. And it scared everybody. Put on the screen here on the bottom right, increased 44% chance of dementia. That's incredibly misleading and really not even accurate. But there are some you can see up on the top right there. Dementia, they mentioned, but kidney failure is another one. Heart disease, we'll talk about exactly what they're talking about there. But I'd like to start by talking about dementia. So again, this comes from really two studies. One was in the New England Journal, and the other one was in JAMA Neurology in 2016. And it was a pharmacoepidemiologic study done where they took essentially older patients over 75, and some were regular PPI users and others were PPI non-users that had no baseline history of dementia. And at 6 years of follow-up, looked at a whole bunch of different things, one of which was dementia. And you can see here, this is the study that's the graph that scared everybody. The dark line on top, no PPI use. You had a much better dementia-free survival than if you were on a PPI, and you had a lower dementia-free survival. Since then, there have been numerous studies in big-time journals, Gastroenterology, JGH, the Red Journal, all disputing that data. Numerous meta-analyses have been done, and they now have found that there really is no association, no good association between dementia and PPI use. And so when patients ask me now, well, I've heard it can cause dementia, or I have a family history of Alzheimer's, should I be taking these? I say, yes, it's safe for you to take, and we no longer believe that it causes dementia, is what I tell patients. Next, let's talk about heart disease. In particular, what that refers to is how it is affected by antiplatelet agents, particularly clopidogrel, because of how they're metabolized. It was thought that perhaps the PPIs could inhibit the efficacy of clopidogrel. Well, this was completely disproven when the Cogent trial came out in 2010 in the New England Journal of Medicine, and you can see there very plainly that there was no difference in cardiac outcomes, whether you were on omeprazole or placebo if you were taking clopidogrel. A couple others, C. diff and pneumonia, those have basically, those have mainly to do with how the PPIs lower the acid that is traversing through your GI tract. There's much more data for C. diff than pneumonia, to be honest, but they both are associated. Kidney disease is another big one to talk about. Shortly after these PPIs came out, there were a lot of case reports of acute interstitial nephritis, which is true. The PPIs can cause interstitial nephritis, acute interstitial nephritis, very, very uncommonly, however. CKD has been more recent. There was a study in JAMA in 2016 and a couple others after that that did show some possible possible associations with progression of CKD, but even if that is the case, it's very, very low. And so you have to weigh the risks and benefit of anything, but PPIs included, for, we don't want you to get erosive esophagitis or a stricture or ultimately Barrett's esophagus and cancer. And weigh it against the very small risk of chronic kidney disease. And this also is why we always use the lowest effective dose. And what about bone mineral density? Well, we're not really sure why the PPIs themselves could possibly cause bone mineral density issues, but you do have some hypochlorhydria associated malabsorption of calcium and B12 with these. You also get some direct gastrin-induced parathyroid hyperplasia. Those are the two big theories why these may cause some bone mineral densities. Numerous studies have looked at this. A lot have showed associations, but none of them, it's all observational data. But suffice it to say, it goes back to what we've talked about with CKD, just the slide before. You always lose the lowest effective dose, and make sure you talk about the risk benefit and why it's important, or why you feel it's important that the patient starts taking them. I just want to talk briefly about surgery, not much, honestly. The main surgery, other than bariatric surgery, obviously, that would help reflux if you lose weight, is the Nissen fundoplication. You can see there, I try to avoid really ever recommending surgery for these people. The main time I would, honestly, is if they have a very, very large hiatal hernia and nothing seems to be helping their symptoms. So spend a little more time here on Barrett's esophagus. So we already talked about what it was. It's squamous to columnar metaplasia of your esophageal epithelium. And it is a progression, a stepwise progression from non-dysplastic, just metaplasia, the Barrett's esophagus, to low-grade dysplasia, to high-grade dysplasia, to adenocarcinoma. And it's diseases like that that are a known spectrum, a known progression from benign to malignant, that are the perfect things to screen for. That's why we do colonoscopies and screen colon polyps and remove them. They have a very well laid out and known stepwise progression from an adenoma to cancer. And it's the perfect thing to screen. But Barrett's is much less common than a colon polyp. So you don't screen the general population, but there are certain times you do screen people. Number one is men. And I'll tell you, I had an attending in my fellowship who would tell me if a woman came to your endo center to be screened for Barrett's esophagus because she has GERD, you screen her husband and have her drive him home because he has a much higher chance of having Barrett's esophagus than she would. So who do you screen? So men with long-standing GERD, that's over 5 years, that have several risk factors. Over 50, obesity, particularly central obesity, that smoke or have a family history of Barrett's esophagus. Those are the people that you screen. So if you see a 55-year-old that's, God, I've really had heartburn for, long time, maybe they're a little bit obese, that's someone that you would, maybe they don't have dysphagia, they don't have iron deficiency or anemia or blood in their stool or chest pain. They don't have those alarm features. They're a man that's had GERD for a while. They're over 50, obese. They smoke perhaps, which is a lot of people. A lot of people do fit into this category. That is someone that you would send over to have an EGD to screen for Barrett's esophagus. And again, because it happens on a known progression, if they do have it, we can prevent them from getting adenocarcinoma by treating their Barrett's esophagus, which is a whole separate lecture. Briefly, refractory GERD, this is a slide here that I want to just mainly direct your eyes over to this part here. So for those with atypical symptoms, don't forget to refer them to ENT, pulmonology, or even an allergist to look at reasons other than GERD that may be causing some of those symptoms. And lastly, the last thing I'll talk about is Baclofen for someone that truly has refractory GERD. They're optimized on a PPI, they're taking them appropriately. Maybe you tried an H2 blocker at bedtime and nothing seems to be helping. Baclofen is a GABA agonist that can be used to decrease transient lower esophageal sphincter relaxations. And remember, the majority of people that have GERD have it because they have frequent TLESRs. This was a really, really small study that came out a long time ago in 2003 in Gut. And essentially up here is reflux episodes. And they put patients on a PPI or PPI plus Baclofen. And you can see that when you added Baclofen, you reduced the amount of reflux episodes. And the reason for that is that you're, in theory, reducing transient lower esophageal sphincter relaxations. I've used it several times, both in and out, since I've finished my fellowship. Some people say they've noticed an improvement. None of them had complete eradication of their symptoms, but it's just something to think about. It's not a great medicine to take because of the side effects and frequency with which you need to take it, but just remember it is there as a possible option to rarely be used if nothing else seems to be helping. So in summary, you diagnose GERD based on symptoms. You start out with an 8-week PPI trial. You do an EGD if there's alarm symptoms, and remember, always use the lowest effective dose of the proton pump inhibitors. Thank you.